Hello and welcome to the module Odo 370, the Division of Endodontics. I'm Dr. Buchanan, and today we're going to be talking a little bit about rubber dam for endodontics. So rubber dam was designed in the United States in 1864, and it's used extensively in endodontics and restorative dentistry. Rubber dam was invented by a dentist in New York called Dr. Christy Barnum in 1864. And I really enjoyed this quote, so I'm going to leave it on for a few seconds so that you guys can read the entire quote. But he mentions how he had many sleepless nights over sad failures and asked himself, how shall I keep the cavities dry? And one day what he basically did is he cut a hole in the napkin protector and placed it over the tooth, and that's how the rubber dam was invented. But you can see that it's been around for a really long time. From 1864. So rubber dam is really not a new concept. It's been around for almost as long as dental amalgam has been around. And why do we use it? There are a couple of main reasons. First and foremost, we're trying to keep foreign microorganisms out of the canal. It improves our vision. We use it mainly, I would say the main reason why we use rubber dam is for safety, so that we avoid ingestion or aspiration of our endodontic instruments or chemicals. It obviously helps with infection control and prevention, and allows us to isolate properly for our restorative procedures. And remember, coronal seal, the provision of a coronal restoration, is still very much a part of endodontic treatments. In addition to this, it can help us to retract our soft tissues, especially our tongue when we're working on something like a mandibular molar, and importantly, it can keep your patient quiet as well. For some patients, keeping them quiet is more important than others. Let's talk a little bit about the technique. So, single tooth isolation is usually effective for endodontic treatment because we're just working on that one tooth. We very seldom have to isolate an entire quadrant, so a single tooth is usually fine. We have guides, which we provide in the clinical wards. I'll show you the guides in a couple of slides. The idea is to punch a single hole in the correct place, and then you can stretch the rubber dam over the wings of your clamp. And I like to place the dam and the clamp as a unit onto the tooth with our rubber dam forceps, and after that release the dam from the clamp's wings and apply the frame for a little bit of tension. So we start with our rubber dam. We're only using nitrile rubber dams in the wards these days. We don't use latex anymore because this can cause anaphylactic reactions in people who are allergic to latex. Here's one of the templates that we have available in the ward. This is the standard template. You can use this for either endodontic treatments or restorative treatments, and you can basically place your rubber dam over the template and then mark the teeth that you want to isolate and then punch your holes accordingly. There is a special template for endodontic treatments. It was provided to us by Prof. Pfeiffer, and you can see in the endo template specifically, the maxillary teeth are punched in the center in the midline, but a lot closer to the top. So for your maxillary anterior teeth from your 1-3 to your 2-3, you'd punch it actually quite close to the top of the rubber dam, and as you move backwards in the maxilla, you could punch it a little bit more towards the center of the tooth. And all mandibular teeth can basically, we can punch a single hole in the middle of the rubber dam, and this will work quite well. We obviously have different clamps depending on the tooth type that we're treating. So you need to select the appropriate clamp. For single tooth isolation, for a maxillary tooth or a mandibular tooth, something like a butterfly clamp pictured on the left is usually appropriate. In the middle, you can see a premolar clamp. That's a lower premolar clamp, but they're quite similar for upper teeth and lower teeth. And then obviously our molar clamps are quite a bit bigger, and you can see that there's a difference in the shape and the size depending on the tooth that we're trying to isolate. You'll notice that all these clamps, however, have wings on them. I quite enjoy the winged clamps. At times, we might need to use a combination of clamps depending on the situation. So bear in mind that you don't have to do single tooth isolation. You might sometimes have to isolate more than one tooth in order to achieve the objective. It's vital that we place a piece of floss onto our rubber dam clamp. This is just in case something happens. If the dam does somehow become dislodged, if we do lose control of our rubber dam, we are always attach a piece of floss to our clamp, so that just in case the patient does aspirate or swallow the clamp, that we have the ability to remove that clamp, so we can basically pull on the piece of floss and get it out. Here's a better picture just demonstrating it. You can attach it either into the holes or onto the wings of the clamp. It's important to use a piece of floss that's long enough so that if something does happen, if the patient does accidentally swallow the clamp, that the piece of floss is long enough so that we can actually retrieve the clamp. So the first step, punch a hole. Remember that your punch has various settings. You can either punch a small hole or a medium-sized hole if you're working on, for example, an anterior or a premolar tooth, and the larger holes in the punch are there for your molar teeth. After we've punched our hole and placed our rubber dam onto the clamp, we can use the forceps to place the clamp and the dam as a unit, as I've described before. After we've placed the dam onto the tooth as a unit, the dam will still be over the wings of the clamp. So remember, it's important to release the dam over the wings so that we get a nice adaptation of the dam to the tooth. And this provides us with great isolation. It's optional to use something like wedgets with the clamps. The wedgets are the yellow rubber bands that you can see there, and they can be threaded through the contact, much like a piece of floss. Remember, you have to put tension on your wedgets to get them through the contact points, and then you can release them, and then they'll expand, and they'll actually help you to keep your rubber dam in place. So I quite like using wedgets when I'm isolating more than one tooth. Obviously, we can also isolate an anterior tooth with wedgets alone if a clamp is inappropriate. Here's a small video that I made. Let's see if it will actually play. And this just demonstrates how quickly a rubber dam can be placed. Let's see if we can get it to work. So there you can see the patient is ready. In this particular case, I've already placed the rubber dam over the wings of the clamp. It's a premolar. As I recall, it's a 2.4 or a 2.5. You ask the patient to open nice and wide. And the rubber dam is placed as a unit over the tooth. Remember, I haven't released the dam from the wings yet, so I can use basically just a flat plastic or a small spoon excavator to remove it from the wings. There we go, we can see it's more or less nicely in place, and now I can grab my frame and just apply my frame, put a little bit of tension on the dam. You'll note that this doesn't take a long time at all. This video clip is only really about a minute long, so you can see that with a little bit of practice, it's really not that difficult to place a rubber dam, and it doesn't take a long time to do it either. So why don't people use rubber dam? It's quite a simple thing to do, but despite this fact, many dentists don't use it for either restorative treatment or endodontics. Whilst there's no good reason, a survey of South African dentists in private practice found that only 37% of dentists routinely use rubber dam when doing root canal treatments. We published the article in the Saudi Endodontic Journal. I would encourage you guys to go read it if you have some time. It is freely available on their website. It is an open access journal. So why don't people use rubber dam? We asked people for reasons, the folks who don't use rubber dam, and the reasons that they provided included the following. First and foremost, they said patients don't like it. And that was about 27% of the respondents. An equal number said that they believe that adequate isolation is possible without rubber dam. The third most common reason was that people have inadequate training and experience when using rubber dam. And the sort of minor reasons were that placement takes too long, that fees are too low to justify its use, and that it wasn't available in the practices that they were working in. And let's have a look at each of these factors individually, and we'll just talk about them a little bit. So patients don't like it. I haven't found this in my experience. I find that very few people complain about having a rubber dam in place, but bear in mind that you wouldn't like it either if somebody did it badly. So if you do a good rubber dam and you can allow the patient to still see and you can allow them to still breathe, they really wouldn't complain about it if you do it properly. So as we mentioned, make sure that your patient can breathe. It depends on whether you like them or not. I'm just kidding. Obviously, it's mandatory, but place it properly and make sure that it's in the correct place, and then the patients won't mind having it on. And also, again, explain to them that it's there for their own safety. And how about situations like this? Well, nobody wants to drink their own abscess, so again, bear in mind it's there for the benefits of the patient, and you must explain this to them. Similarly, remember we irrigate, we're going to be using things like sodium hypochlorite, we're going to be using EDTA. These irrigants don't taste great either, so it's in the patient's best interest to have the rubber dam on. How about those that believe adequate isolation is possible without a rubber dam? Well, have a look at this case. I took this off of a dentist's website, and I think they were sort of trying to demonstrate the same thing. But if you have a look at this picture, seriously, do you believe that these teeth are adequately isolated? Do you think that this is appropriate? Is this a safe situation? I don't think that we can say that. So really, it's not possible to get really good or excellent isolation, and this is not going to keep the saliva or additional microorganisms from the oral cavity out of somebody's tooth. So adequate isolation really isn't possible without a rubber dam. How about inadequate training and experience? Well, in the oral and dental hospital, rubber dam is mandatory for every single endodontic procedure that we're going to do, and this includes emergency root canal treatments. Bear in mind that you are never in your training. No fourth year students or fifth year students is ever going to complete a case without rubber dam. You're going to do between 5 and 7 cases in your fourth year and at least 4 molars in your fifth year. And in addition to this, you're supposed to be using rubber dam for all your restorative treatment where you're using composite as well. So is this really true? Can we really say that people don't know enough about rubber dam, that people have inadequate training and experience? I can't imagine this to be true, and I don't think that this is an accurate statement. Either way, remember that you won't fall back on something like inadequate training and experience if there's a claim against you or if there's a serious problem. So if a patient does aspirate or ingest an endodontic file, it's going to be indefensible in a court of law. So you really can't say that you don't have enough training and experience to use the rubber dam. There are numerous case reports in the endodontic literature of ingested and aspirated instruments, so don't think that this won't happen to you. It does happen. Please go have a look at, in your own time, at this YouTube video of an endoscopic removal of its number 8K file that was actually ingested by a patient and it needed to be removed endoscopically. How about placement takes too long? Well, it really shouldn't for a single tooth, and I think it's well demonstrated in the video that I showed you guys a couple of slides earlier. Obviously, when you're a beginner, when you're a novice, it's going to take you a little bit longer, but bear in mind as you proceed through the course, as you proceed with your career, your speed is going to increase when doing these things. There are challenging cases, however, but I'd like to say that on average, I spend no more than 1 to 2 minutes on placing a rubber dam, especially if it's a single tooth isolation, then it's really only a couple of seconds. My advice to you when you do get to private practice as well is to train your assistant well. Train your assistant to punch the dam in the right place. Train them to have everything in place. And of course, if you practice it as well, it really isn't going to take a very long time to place a good rubber dam. How about the fact that fees are supposedly too low to justify its use? I took a screenshot of these dental tariffs from Dentist Medical Aids. So that's medical aids. It used to be Bonitas, MediHealth. And if you note there, your 8304 rubber dam per arch, you can charge. I compiled this in 2019, so you can see that the fees were 107 Rand for each rubber dam that you place. If you compare that to an extraction, a first extraction 8201, the reimbursement for that is 137 Rand. So you're going to be earning similar amounts of money for placing a rubber dam as compared to extracting a tooth. I always like to laugh at the reimbursement for an additional tooth extraction 8202. You'll notice that placing a rubber dam is the equivalent of pulling out 2 additional teeth after you've taken the first one out. So the fees, even at medical aid tariffs, aren't terrible for placing rubber dams, so you should place them. The fees are not too low to justify its use. I had a look then afterwards to see how much rubber dams cost. And I went onto a website called Want It All, and we found that a pack of 52 rubber dams was retailing at 655 Rand. And then I went on to Dental Warehouse, Henry Schein now, and we found that thin rubber dams for a pack of 36, 122 Rand, and for the medium dams it was about 183 Rand. So you can see that if you're charging 107 Rand for a rubber dam, you could almost buy a whole pack of 36 rubber dams after you've charged for just placing one. So are the fees really too low to justify its use? I did something even more dangerous. I decided to do some maths after that, and I want to start off by saying that whilst your medical aid tariffs are probably too low for everything, if you do a simple calculation, and let's say you did 3 emergency root canal treatments a week and 2 root canal completions, but it could be fillings as well. Let's say you just used it for restorative treatment. And let's say you only did about 5 procedures per week that required rubber dam, and you charged at 107 Rand per use, you would find that in a year's time, if you took no leave, that you would be earning almost 28,000 Rand in terms of turnover for it. And if it's 655 Rand for a pack of 52 dams, and you needed those 260 dams for a year, you would need to buy 5 packs, and those 5 packs would only cost you about 3,300 Rand, and your profit would be about 24 or almost 25,000 Rand per year if you were using and charging for all the rubber dams. And that's if you used the expensive ones. If you used the slightly cheaper ones, the thin dams that I showed you earlier, at 122 Rand a pack of 36 dams, then you would require 7 packs for the year. Those packs would cost you 885 Rand, and you would make a profit of 27,000 Rand for the year. And what can you do with that money? After that, I went on to Flight Centre and we had a look at some specials. Bear in mind again, this was 2019, and I found that a trip to Mauritius, return flights, 7 nights, you could get a package for about 9,000 Rand. So that means you could take 3 people to Mauritius just for placing rubber dams. And if you were the South African soccer player who thanked both his wife and girlfriend, you wouldn't even need to choose. You could take both your wife and girlfriend to Mauritius for a week. How about rubber dams that are not available at the practice? Let's discuss that in a little bit more detail. I found that finding to be quite disappointing. Although you don't know where you'll end up working, I did work in some practices where rubber dam wasn't available, but I always bought my own because I didn't like to work without it. That's until I bought my own practice. It's a good idea to try and work for yourself, try to be your own boss. And just remember again that the excuse that the rubber dam wasn't available in the practice that I was working in is never going to be a good legal defense if a complication does occur. And that's typical of bosses. They tell you to do something, and then if there's a problem, the next day they're going to ask you, but why did you do that? Let's talk a bit about pre-isolation buildup. Bear in mind that often teeth that require root canal treatments will have very, very large carious lesions on them. And in these cases, we might need to build the tooth up first in order to get good rubber dam isolation. Dr. Arnaldo Castellucci is an endodontist from Italy, And I quite like his quotes. He always says that when it's not possible to isolate the tooth with a rubber dam, you as a clinician have two options. The one is to make it possible, and the other option is to extract the tooth. There is no other choice, and I fully agree with this statement. So oftentimes we'll find that if we do have deep caries or if we have done a preparation, that the rubber dam might not seal adequately. And you need to ask yourself this beforehand, before you excavate this caries or before you do that preparation. Am I going to get a good seal on this case if I need to do a root canal treatment? And then this will guide you as to whether you need a pre-isolation buildup. If necessary, you can basically just do a composite buildup before placing your rubber dam. Remember that these buildups don't have to be a work of art because it's a functional buildup, so you don't have to build it up to look exactly like a non-restored tooth. It doesn't have to be a work of art. It's really just a functional thing. So we want a nice sound ring of tooth structure or restorative material so that when we place our rubber dam, we get a nice seal so that the irrigants don't leak out under the rubber dam. In some cases, for example like this, if the tooth is already heavily restored and the existing restoration or the composite was heavily compromised, we might need to go to more advanced options. So in this particular case, we had to make a temporary crown. And there's a temporary crown in place. Alternatively, if there's very little tooth structure remaining, we can use either a molar band or an ortho band and cement this band around the tooth if we have too little tooth structure. This is actually a nice way of doing things as well because it can help us to prevent fracture on the tooth, especially if there is some cracks in the tooth or if there was a large pre-existing amalgam. Then a ortho band is a good option for a build-up. How about secondary isolation? As we've mentioned, it's not always possible to get a good seal with your rubber dam alone, so sometimes you'll find that even if you've done your composite buildup, for example demonstrated in this case, we might still not get a good seal on the case. And in this instance, we can actually use some secondary isolation. We'll talk about that a little bit more in the next slide. Here's a case. It's a upper first premolar in the maxilla, and you can see that we're going to do a root canal treatment on this premolar, but you can see that there really is quite little tooth structure available for our clamp. So what did we do? After we excavated the caries, we found that it was quite difficult to place our clamp, so we did a combination of things. Firstly, we built the tooth up with a little bit of composite. If you have poor retention of your rubber dam clamp, it's actually possible to etch, prime and bond and actually place little buttons of composites on both the palatal and the buccal surfaces of the tooth, and these little buttons of composite can actually help to retain your rubber dam clamp if it keeps on slipping off. So bear in mind, you can do that. You can try to place your clamp first, and if you feel that it's quite loose, you could just etch, prime and bond a little bit over the teeth of the clamp to help keep it in place. And on the right hand side, you'll see that very white stuff that we've placed in order to cover the gaps in the rubber dam isolation. That's basically secondary isolation with something called opal dam or liquid dam. These are chalking agents or unfilled resins, and you basically place them. It looks a little bit like flowable composites. It comes in a syringe, and you can actually syringe it over the gaps in your rubber dam. It adheres to your rubber dam, but it doesn't bond to the tooth structure. You could, technically speaking, use expired flowable composite as well, but bear in mind that that will be quite an expensive option. So if you have some expired flowable, that's great, you can use it, but I wouldn't recommend using flowable that you can still use for restorative treatment because it will be too expensive to obtain secondary isolation in this manner. This is just a picture of opal dam. You can see it comes in a syringe. It's similar to sort of flowable composites. This particular one is green. They do come in different colors. The color doesn't really matter. Remember, in the oral and dental hospital, our appointments can be quite long, 3.5 hours, 4 hours if you have a double morning session. So the rules are as follows. If the patient needs the bathroom, the rubber dam must stay on. However, you must remove the endodontic files from the tooth if they are going to go to the bathroom or take a break. And if you do forget, we're going to send you down the corridor after the patient to retrieve the files. Otherwise, this type of thing happens. And no, this is not a picture just of a toilet. If you notice to the right-hand side of the toilet, there's a little white thing. And what is that little white thing? It's actually an endophile that fell out of somebody's tooth. And you laugh. I laughed as well when I took these pictures, and it's always funny. But the trouble is, if we can't find an endophile, we have to consider the fact that it might have been swallowed or aspirated. Remember, the standard of care for a missing endodontic instrument is that we need to take either a chest or abdominal x-ray, and we need to do this for up to 3 days afterwards, every day, to track the movements of the instrument. So it is actually quite a serious issue. In the oral and dental hospital, since I've been there, we haven't had an ingested or an aspirated file. But in the 4 years that I've been around, we have actually had 2 burrs that have been swallowed by patients. And we did do this. We did send them across the road. We did have to get abdominal x-rays for 3 days. We did have to track the progress of that instrument. So it is quite a serious thing. And this can all be prevented if we just use a rubber dam efficiently to start with. Radiography with your rubber dam, it can be a bit tricky. When a rubber dam is in place, it can be a little bit more difficult to actually get your sensor into the right place and to get nice alignment. It's advisable when you do take a radiograph with your rubber dam on, remove only your frame. So the clamp and the dam must stay on because we have to try and maintain our isolation at all times. It doesn't help to try and take the rubber dam off when we're taking an x-ray because then we're exposing the root canals to the oral bacteria to the saliva, and it can recontaminate the root canal system. So we can't take off our entire rubber dam, but you can take the frame off in order to get a better radiograph. Always use your RIN apparatus. It will help you just to align the radiograph nicely. You could also use a snap array. I give a full lecture on endodontic radiography at the beginning of 4th year, so we'll cover it in a little bit more detail in that lecture. When can you remove the rubber dam? It depends if it's the first or the last visit, but essentially you need to have some kind of coronal seal in place first. So if you're not obturating on the same day, after you've placed your medicaments, after you've dried your canals, you can mix and place your temporary filling material first, your IRM or your glass ionomer. Place it into the tooth. Remember, you must have a cotton pellet in place as well if you're restoring temporarily, so that you don't get any of the restorative material going down the canals. And if you're completing the case in the same day, after you've burnt off your GP, you can place your resin-modified glass ionomer, something like Vitrabond, and then you can light cure it. At that point, you've established a coronal seal for endo. So if you needed to at that point, for some reason, you could take off the rubber dam, but it's obviously a lot better to restore the tooth with the rubber dam in place because you're going to have nice isolation. But obviously in something like a class 2 situation, if you've done a single tooth isolation, you might not be able to actually get a nice contact with the dam still in place. So in that particular instance, you could, for example, take it off, but not before you've placed your resin-modified glass ionomer and light cured it first. So you need to first protect your root canal system. You need to provide a coronal seal before you remove your rubber dam. It doesn't help to remove it prior to that because obviously, again, as we've mentioned, the saliva, the bacteria in the mouth can then get back into the root canal system, and that negates everything that we've been trying to do with our isolation to start with. In conclusion, your rubber dam isolation is critical for the provision of safe, efficient root canal treatment. Remember, it's there for the patient safety, but also your own safety. Like any other skill, it's going to be a little bit tricky at first, but as time goes by, it will be a lot easier to master rubber dam. Please, 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 guys, don't let older dentists in private practice, when you go work for someone, don't let anybody tell you that you don't need rubber dam for root canal treatments. I think we've demonstrated quite nicely in this lecture that you can have serious complications if you don't use it. It will be indefensible if you do get charged with something, if there is a complaint against you at the HPCSA or even a civil case in court. It will be indefensible if you didn't use a rubber dam, and it's not something that's going to be difficult for you for a long time. As you practice with time, the skill is going to become a lot easier. Thank you for your attention.